Shubha Madhyana. Welcome all. I welcome you all to session 8 of Shalya Tantra online classes on Tadvidya Sambhasha Parishat page on FB Facebook Live. Before we start today's session, as usual, we will start it with a prayer. Om Namami Dhanvantarim Adidevam Surasurairvandita Padapadmam Loke Jararubhayamrutyunasham Dataramisham Vividaushadhina Om Shanti Shanti Shanti. Hello again. So until last session, last class, we dealt with almost the detailed aspect of all the basic fractures and dislocations. So as I told in the last session, we are left behind with two main important topics under this musculoskeletal injuries. So that is especially injury of that of the bone tissue. So that is very important, that is the infection of the bone. And the next is the Chikitsa aspect that of the Bhagna, that is from the Sushrita Samhita. So today in current session, we will be dealing with the osteomyelitis part of it. We will not be dealing with the detailed aspect of all the infections of the bone. Maybe if time permits later, once we cover all rest of the portions, we will take up those which we have left behind. But as of now, it's important portions will be tried to cover. So today we will be starting with infections of the bones and joints. So under that, okay. So under this heading, we will be taking up osteomyelitis today. This is very, very important. It is not just with respect to the exam point of view, but it is also very important with respect to the treatment part, treatment aspect. When we actually, it is very important for us to diagnose osteomyelitis, because any further when we go through today's class, we will get to know like the main incidence of chronic osteomyelitis in developing countries. The main prime reason is because we are unable to diagnose it at the acute stage and proper treatment is not being done. So that is why it is very important even from the treatment aspect of it. Now, what osteomyelitis means? So this means in simple words, it means it is infection of the bone. Okay, so this is in basic terminology or the basic meaning, simple meaning of osteomyelitis. Now, again, this is of two types. That is, we have acute and we have chronic. Both are important, whereas acute is very, very important because once the osteomyelitis, because of delayed diagnosis or inadequate treatment, it moves through the next, that is chronic stage. Then usually it cannot be managed conservatively. So then conservative management goes for a failure. Then it is always a surgical intervention, but still you're not sure, but you're still not 100% sure or for the good quality or the positive outcome of your surgical intervention. So that is why identifying osteomyelitis at acute stage and giving it an adequate treatment is very, very important aspect of this entire scenario. So moving further, as we have been doing till till previous sessions, before we take up any topic, we started with the relevant anatomy and only then move further. So here again, now we will see acute osteomyelitis. Okay. Now before we move into osteomyelitis proper or the classification of acute osteomyelitis proper, we will first deal with the relevant anatomy. Okay. Before I don't forget, acute osteomyelitis is again of two types. That is, we have primary and we have the secondary. Whereas primary is an hematogenous spread and the secondary is usually because of trauma or because of a compound fracture. So this primary is a hematogenous spread and this is external, usually because of fracture or trauma, etc. And this is increased incidence is the hematological one than compared to the secondary acute osteomyelitis. So usually seen is the hematogenous spread. So that is called as the primary acute osteomyelitis. Okay. Now we will move on to the anatomical part. So now we are dealing with the relevant anatomy. So what are those important things we have to consider while we are studying the anatomy? So the entire focus with respect to the relevant anatomy of, with respect to osteomyelitis is the metaphysis. We studied the different parts of bone, right? In the first session, we saw epiphysis, metaphysis, and diaphysis. So metaphysis is that, which it's a bridge between the epiphysis and the diaphysis. So the entire picture of whatever happens in osteomyelitis, the main focus is at the region of metaphysis. Now, why metaphysis is the favorite, site for osteomyelitis, we will be seeing now, because this is very, very important. It is not sufficient to just, move through the signs and symptoms and the diagnosis. We have to, it is very important for us to know where it happens and how exactly osteomyelitis happens. So for that, now we will move on to we will try to focus on to a detail about the metaphysis. Now, especially, so, this is almost like Amsha Kalpana. So what we are doing, at the whole, we are taking the bone anatomy, and under that, now we know that, the metaphysis is the most prone site of the bone tissue to happen. And even in that, it is, metaphysis of the long bone that is usually affected. So this is again another Vishesha Kalpana, or it is an Amsha Kalpana out of the whole thing. Now, in the long bone, what is more relevant, that is whether it is the cortical part, the cancellous part, or it is the vascularity, where exactly is this pathology building? So again, the next Amsha what we have to look for is the vascularity, or the vessels that run through at the level of metaphysis. So it is very important for us to know that it is the blood vessel fashion or the design of how the vascular structures or tissues are placed at the level of metaphysis, which forms the basis of the building up of pathology. So that is very, very important. So with respect to osteomyelitis, at the region of metaphysis, the vascular supply is the main role that is got to play with the osteomyelitis. Now we will see how it actually happens. So now we know that it usually happens in that of a long bone, right? So suppose we are drawing a typical long bone. So let us take tibia. Okay. 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 So let us take an example of the tibia bone, the upper end. Now we know that this is the diaphysis, this is the metaphysis, and here you have the epiphysis. Now between the epiphysis and metaphysis, we have something that is the growth plate. So suppose you take, this is the growth plate, this is the epiphysis, and this is the metaphysis. Okay. So now what is very important here is that, first of all, metaphysis is a highly vascularized zone. So that is first important thing. Now next what we have to look for is the medullary arteries. So in the first session we have seen the vascular supply, the arterial supply for the bone. So then we have learned about the medullary artery. So what happens here, what is the role of medullary artery here is that the medullary artery, from the diaphysis, it comes up. Now once it is reaching near, it comes under the growth plate. So once it is reaching the metaphyseal region, it branches into several other capillaries. Okay. So it branches into several other capillaries. I will be drawing only 4 of them so that it is convenient for me to pictorially represent. Okay. So this is the medullary artery. Now the next part, what happens here is that wherever, here it branches to several capillaries, and the venous system as usual, it is the general anatomy. So the venous system begins from here. So what happens with respect to the venous system is that Okay, the venous system will start, from the metaphysis, it starts draining towards the diaphysis. So you have, okay, okay, so we have all these branches, and then we have the venous system. So here we have the artery, here we have the vein. So this artery is taking the nutrient blood from the diaphysis level to the metaphysis, and here what happens, from here again the venous system begins. Okay, it drains the blood from the metaphyseal region towards the diaphyseal region. Now, what is very important thing for us to know here is that the vessels in this zone, you know how it is arranged? It is arranged in the form of a loop, right? So you have a loop here, you have a loop here, we have a loop here. Now, this loop arrangement is the basic, arrangement is probably, it is said that it is that which is responsible for the metaphysis to be the favorite site for, for the pathogens. Why? Because at this area, the stasis of blood is more. It is more than compared to the straight vessels, right? So here, in the course of a nutrient artery, the capillary, and then the development of the venous system, here in this region, in the metaphyseal region, this normal anatomy of, looping between the arterial and the venous system is said to be, it is probably said to be one of the most important and common reasons that, makes this metaphyseal region favorite spot in the bone tissue for the pathogens to, house themselves. That is because wherever there is looping, the stasis is more. So once the stasis is more, the pathogens can pool in that area more than compared to the other part, wherein the circulation is more free and it is more in a less more, the speed is also more, right? The ease to flow is also more in a straight vessel. So because of this reasons, the metaphysis is one of the main, site. This becomes very, very important because as and when we move to the diagnosis aspect, especially osteomyelitis is one such disease which we have to, diagnose at the clinical level. And for that to know, we have to know that metaphysis is the more prone region of the bone tissue. Otherwise, it is difficult. It is one of the prime important aspects of the diagnosis. So that is why I'm stressing a lot on this. So I hope this is clear. Now, why, the metaphysis is the favorite spot. Now, the next thing. First, we saw, in the anatomy of the bone, why the metaphysis is the favorite spot. Now, next thing is, with respect to the joint type. So what is that we have to see with respect to the joint type is, so we have two kinds, that is we have intra-articular or intracapsular and the extracapsular joints, right? It can be called in both intra-articular or, or capsular and extra-articular joints. So we can take the examples. Like how do we get to know? So now suppose this is one bone, okay, and this is an other bone. So here what do we have? So here we have the metaphysis of this bone, we have the metaphysis of this bone, okay. We have the growth plate, we have the growth plate, okay. This is the epiphysis and this is epiphysis of this bone. Now we have the articular thing that is adhering at the junction where the epiphysis and metaphysis meet. From there we have the articular tissue, okay. So this is the normal bone. Now this is extra extra articular, okay. Now for the next thing, here what is extra articular is, we are speaking with respect to the metaphysis, okay, not to get confused. So here, where is the articulation? The articulation is at the junction where the metaphysis and epiphysis is. So the metaphysis is extra articular in this case. Now suppose in the last class we saw the dislocation of femur. Now taking the same thing into account, suppose we try to draw that. So suppose you think this is the cavity. Okay, and next we will draw the head of the femur. Okay, so we have the plate there, and next we have, the neck. We have the greater trochanter, we have the lesser trochanter. Okay, somewhat roughly, if this is depicting femur, and now we have, the pelvic bony structure here. So where are we getting the articulation here is, so suppose we continue it like this. Okay, so this is the bony articulating part. So here in this case, what happens? Okay, so this is the articulating tissue. Okay, here what do we have? So this is the epiphysis and this is the metaphysis. Now where is metaphysis lying here? It is intra-articular. A part of metaphysis is, it is inside the articulating tissue or the capsule. So this is very, very important with respect to osteomyelitis. Why? Because there is a special feature of this growth plate. What it is that, now we know that metaphysis is the favorite spot for the pathogens to harbor. This growth plate is a strong plate that, it resists the movement of this pathogens to invade the growth plate so that it moves into the joint. So the growth plate acts as a policeman to arrest all these pathogens at the metaphyseal level only. So the pathogenesis is restricted, below the growth plate most of the times. Now, what happens now here in case of an intra-articular, a joint is that intra-articulation. So here metaphysis itself is a part, inside the articulating tissue. So whatever is the pathogen here, it is easy that, through this, now when we move further towards the pathology of how exactly it happens, we will see how it disrupts the periosteum. But for as of now, it need not pass the growth plate to move into the joint. Whereas the metaphysis itself is a part of the capsule. So when it is disrupting, the periosteum, then it enters into the joint space. Now the pathogens which were here in the metaphysis are now here in the joints. So what you could think could end up with, the patient will end up with another problem, that is acute septic arthritis, right? Or pyogenic arthritis. That is what the patient will end up with. Or it is more relevant to, name it as pyogenic arthritis, because we are not dealing anything with specific. Pyogenic arthritis. So this is one of the complications. Suppose we have an intra-articular joint, osteomyelitis or femur occurs, we always have to, when the patient presents to us in an acute phase, we also have to think about this. Suppose if the patient is presenting a little late, okay, so in that case, we have to also give an importance on this. This is one of the major complications of an intra-articular, joint. Okay, so I hope the relevant anatomy of, why metaphysis is the favorite spot for the pathogens to build up, and the difference of why intra-articular is more vulnerable for joint space infection, and how, extra-articular in bones with extra-articulation, metaphysis is outside the articulation, how, the joint is spared off or it is protected from being infected. So this is the basic thing. So now we move on further to the etiopathogenesis. Okay, now we move on to the etiopathogenesis. Okay, we move to the etiopathogenesis. Okay, now of the various, we said that, pathogens, metaphysis is the favorite spot for pathogens. Now, which are the commonly seen pathogens here is that, so we have the staphylococcus, which is the most common. We also have strepto and the pneumococcus. So, is more common. We have streptococcus and pneumococcus as well. So these are the most commonly invading pathogens. Now, how do they come to this site of metaphysis is that it is usually what we saw in case of acute osteomyelitis. It is of two types. One is the hematogenous spread and the other is the external because of a fracture or because of injury. So here in case of hematogenous spread, the primary focus is somewhere else. Usually it is very difficult to identify the primary focus until and unless, the infection at the level of primary focus is evident. Otherwise, we will not get to know where is the site of primary focus from which the pathogens has taken its root. So when we are reading when we deal to know that why Rakta is considered as Chaturtha dosha, or even during the time of Kriya Kala when we read, now we know that how the doshas from the Rakta Dhatu in various forms of permutation and combinations, it moves in various parts of the body. Same thing is here, that is, it's a hematological spread. The primary focus is somewhere else. The dosha, when it increases, so when it in the Rakta Dhatu as a vehicle, it moves, it takes prasara and it moves and takes sthana samshraya at the level of the bone joint. Okay, the bone, not the joint, at the level of metaphysis of the bone. So here, which is the Kha Vaigunya, here we cannot tell it as Vigunata, because it is a natural anatomical structure how it is there. But because of the the design of that particular structure, because of the pooling, that is why the pathogens mainly in the bone structure, it is only that place where the blood can pool easily. So that is why it the sthana samshraya or the vyakta avastha of the disease happens at the level of metaphysis. So here it is hematological spread, usually from another primary focus. Okay, so from the primary focus through the blood circulation, it comes when the pathogens are at the level of the medullary artery, so it comes up at the level of metaphysis, it lodges. So that is how the entire thing happens, and the most commonest are the staphylococcus, streptococcus and pneumococcus. Okay, now the next thing what we have to see is we saw that the long bones are the favorite, or it is usually the long bones where we can commonly see the pathology of osteomyelitis. Now, which are these long bones are that? It is, first is the lower femoral. Compared to all the other, okay, the metaphysis of the lower part of the femur has the highest incidence. Okay, it has the highest incidence. Then you have upper tibia, we have upper femur also, and we have the upper humerus. Okay, so these are the most common sites for the pathology of osteomyelitis. Okay, now we move on further to the actual pathology, what happens exactly. So, fine. So now what happens? So we have a bone. Okay, we have a bone. So now here there are the vessels, and there is the pathology. I mean the pathogens are they are here. That is at the medullary region. Okay, that is at the metaphysis. Now what happens is that now the bacteria is here, so that what will the host bone tissue do? So the first thing it will do is it will generate a inflammatory response. So the first thing what happens is the host tissue or the host body will, the immune system will generate a inflammatory response. Now because of inflammatory response, what happens? So there will be bone destruction, and also there will be production of the inflammatory exudates. So because of this, what happens? There is bone destruction starts happening, begins, okay? And also we have inflammatory exudates. So this is very important. Inflammatory exudates and the pus. Okay, so this will start developing. Now, what once the pus starts developing in the medullary cavity, it spreads in various ways. Now, this is the basic triggering point of the further pathology. So, this is very important. Formation of pus and the exudate, what gets collected in the medullary region, is very important for the rest of the pathology. Now, as we have seen, we have the growth plate here. Okay, we have the growth plate here. Suppose we consider this is the, the articulating tissue, okay, the cartilage. Now, we have the epiphysis here, and this is the metaphysis with the collection of pus. Now, there are various ways actually how this pus can move. Now, consider the same thing what we have drawn for the pathogens. Now, consider this is the accumulation of the pus and exudates, okay. Now, in what all fashion that does this pus move? So, the first is along the medullary cavity. Okay, the first thing is this pus to move is along the medullary cavity. Suppose the first one we call it as A, it is along the medullary cavity. So what happens exactly here is that the pus trickles down the, the cavity of the medulla here. So what do we have here? We have the other arteries and venous system, right? So we have the medullary artery and we have the medullary vein. So once pus starts trickling down, it will cause thrombosis at these vessels. Okay. So once there is, thrombosis of these vessels, the first thing to happen is what? The blood supply gets arrested to that particular region, right? So this focal blood supply is lost. Okay, that is what happens when it moves, through the medullary cavity. Now, the next thing what we have to look for it, there is another chance of this pus moving outside the cortex. That is outside. Okay, how this is the second direction. That is outside the cortex is the second movement of this pus. Now, how that happens is that now we had studied something called as Volkmann's canal. I think in the first session or the second session, I have made a mention on this and on how it is placed and everything about this. Almost briefly we had gone through this. So here, when it is moving, outside the cortex, how the pus moves here, it was a cavity, so it moved easily. But to move, through the cortex, it has to have some channel. Now that channel is nothing but the Volkmann canal. So through the Volkmann canal, what happens? The pus starts moving towards the cortex. And there what it will do, it is such that it will not first pierce the periosteum. Now suppose we have the periosteum here. So again, that is why it is important for us to, what we saw in session 1 about the basic anatomy and physiology, because all this is very important. Suppose if somebody is looking to today's video fresh, then you can actually go back to session 1 and just, brush up the basics of anatomy and physiology on the bone tissue. So suppose now this is the periosteum of the bone. We also saw that periosteum, covers the rest of the region of the bone, like leaving that part of the articular cartilage. So from here we have the periosteum. Now whatever is the pus that is coming through the Volkmann's canal, it will start, accumulating subperiosteally. That is important at the first stage. Okay. So we have the collection of the pus subperiosteally. Now what happens? So here there is collection and collection, because of which what happens? The periosteum is, it gets lifted up. Okay. So because of the collection here, the periosteum gets lifted up. Okay. As and when the collection increases. Now, the pathology is still there. It is not identified. Still what happens at the level of, during the formation of pus, obviously inflammatory responses would have already being seen. The systemic responses are seen. That is why I told at that stage when it is, when it is failed to diagnose, all these things, the pathology will continue, the Kriya Kala will continue. So here what happens? Again here there is increase of the dosha. It keeps on increasing. The X rates keep on increasing. Finally what happens? At one point the periosteum is unable to, bulge more. So finally it, it gets punched out or it gets opened up. So what happens now when it gets opened up? So what we have, so the next thing is the pus will move out. So here what do we have? Here we have the, the rest of the muscle tissue and everything. So even after that, if it still continues, then finally we have the skin here, right? So this is the skin. So it's, the pus again comes at the level of muscle tissue. Still nothing is being done. So finally it, the skin also opens up. And finally what we have is a sinus, that is deep connecting to the bone. So this is how the development of a sinus happens in case of an osteomyelitic bone. So I hope it is clear on how the secondary movement of the pus towards the cortex region finally ends up with the formation of the sinus. Okay. Now, yes, one more thing what we have to see is in the due course, when the periosteum gets disrupted, same thing as we saw here, the periosteal vascular supply also is disrupted. So because of which the vascular supply to that part of the periosteum and the cortex is also disrupted. So again here what happens is that there will be blood supply will be hampered. So once the blood supply is hampered to the bone, so that segment of the bone, it is rendered avascular. So if it becomes shortly, it becomes a dead bone, that is a sequestrum. Okay, so that is how that area of the bone becomes dead because of the compromised vascular blood supply. Okay, now this dimension, what we saw the pathology, this could be such that it could be for a very small confined region, or in some cases it is also that the entire diaphysis can be involved in this particular pathology. So here if we are talking about the Kriya Kala, so it's so beautiful, right? Like we often do come across the application of Kriya Kala for various pathologies. So here it is so beautiful that, so here we have the Dravya Vriddhi keeps on happening. So because of which it gains the, Gunataha Vriddhi, wherein it gains the potential for Swamarga, Anyamarga Gamana. So from its medullary side, it will gain the potential to move to other sides. So in the course, what happens? So this is already a site of, Kha Vaigunya. Wherever it moves, that part of the periosteum, again because of the continuous increase in the drava, that is in the quantity of the dosha, what happens? There is disruption. So, as it is beautifully said, Setum avadarya anyena udakena vyamishram bhavati. So that is what happens. The doshas comes out and here it comes in again, everywhere there is vyamishrata of the dushita tattva here in the, which was priorly prakrita, now that is also becoming dushita. So we have the entire region. So at the end, even then if the Kriya Kala is not attended, what happens is that it comes to the Vyakta and Bheda Avastha, wherein even the skin or at the level of Tvak also it gets opened, and then we have the Upadrava, that is the formation of the sinus tract. So this is how beautifully, it's not just in reading things and, restricting themselves only to, for a 10-mark question of Kriya Kala or something like that. It is important for us to try and keep on applying the knowledge, the basics and the principles of the knowledge to every vyadhi. This can be possible with every pathology what we read. So, but in this case, it is very beautifully, we can correlate. Especially in case of chronic osteomyelitis, we can even appreciate the Leena Avastha of the Kriya Kala. When we move further, I will try to tell that later. Okay. So the next thing, I forgot to mention another movement. So first direction is A, then we have B. Okay. The third is C. Now, C in case of, we have already seen it before. In case of intra-articulations, we saw that how the pus, it moves into the joint space. Here it doesn't happen. It is very rare because growth plate is very, very resistant to the pathogens. Suppose, you picture the entire scenario in case of an intra-articular joint. So in such cases, the third type of movement is to, into the joint space, so that when the pathogens go into the joint space, what happens is all the, they could end up in septic arthritis, various forms of pyogenic arthritis in general, if we have to say. So this is C. So this is the movement of, the pathogens. So this is the basic pathology of osteomyelitis, of acute osteomyelitis to be very specific. Because, in cases of chronic osteomyelitis, the pathology doesn't start from the region of metaphysis. All that would have happened earlier. So usually in cases of chronic osteomyelitis, there are acute exacerbations. Okay, so that is the reason, where conservative treatment helps only in cases of acute exacerbation, but not in the cure of the disease. Patient sometimes in case of chronic osteomyelitis, he comes to you when, the sinus is already evident. So already this part of the pathology is complete. Okay. Now, what do we move forward? The next is the diagnosis. I think in today's class we might be able to complete only acute osteomyelitis. That's okay, as the time permits. Since it's a very important topic, I do not want to rush through. So next is diagnosis. So here what do we have? As I told you, first thing what we have to very important is the diagnosis of osteomyelitis is clinical. So this is very, very important. Then the investigatory part, clinical diagnosis plays a greater role in case of osteomyelitis. Another thing to be seen is usually acute osteomyelitis, the incidence is more in younger children, and that too, the hematological spread is more common. Okay. For example, the child may be having, tonsillitis. The primary focus might be there, but because of the spread of the pathogens through the blood, he might end up with a hematological osteomyelitis. But usually, sometimes, always the patient comes to you where the parents bring their children with telling that usually they give a history of fall or some trivial incident like that, after which they say there is severe pain at the region of some end of the limb. So at either of the end of, we saw which is the more prone part, especially of the long bone. At the metaphyseal end, they say that the child is complaining pain of. So that is the usual presenting way of osteomyelitis. Okay. So now moving on to the the presenting complaints we saw already. So what I told until now are the presenting complaints that usually they complain of an acute onset of pain. That is very important. Okay, we have acute onset of pain. That is very important. And so obviously when it is there, with systemic features will all accompany. You have all the features of inflammation. There will be fever, there will be redness, there will be pain. That is obviously there. It will be tender. The region will be tender. All the systemic symptoms are also evident. Okay, so this is the presenting complaint. Now suppose you move like on examination. What are the things we can look for is, first thing is the child is febrile. Okay, because of the inflammatory response. Okay, and usually the child looks dehydrated, and there are all the classical symptoms of inflammation. Okay, Kaler, rubor, Dohler, all of them classical signs of inflammation. And the next thing what you have to look for is like that. This is very important. That is, you have a localized metaphyseal bone pain. So this is why I told why we need to know the relevant anatomy, as why metaphysis is one of the prone bone part where the osteomyelitis could happen. So when you try to palpate the region of metaphyseal end of the long bone, whichever bone the child is complaining of pain, so when there is pain not at the level of joint. So now when we move on to the differential diagnosis, we will see how you can actually, even in septic arthritis, you have features of inflammation, you have pain in the limb. So in certain cases, how can you differentiate? Is merely, clinically, if you have to differentiate, it is because there you have pain at the level of joint, but here it is not at the level of joint. It is down at the level of metaphyseal region. So this is important. So what else do we see at the level of examination is that, suppose, even after 48 hours, even before 48 hours, the child is not brought to. So when the pus has trickled, subperiosteally towards the muscular plane, then you can, features of abscess. So when you palpate, you can feel the features of abscess, because from the bone level, it is ended up in the muscular plane. So you can feel the abscess. Now this you can feel only when, the patient has not come to you in an early stage. So this is the next thing. So I think these are the basic, evaluating symptoms. Now, next, moving to the investigation part. So, what are the investigations that are going to aid our diagnosis? Coming to the hematological investigations. So, coming to the hematological investigations, obviously there is leukocytosis and there will be an increased ESR, right? So, this is the first one. Now, moving on to the X-ray. Okay, now when will an X-ray help us? So it is very, very important that the earliest sign to appear on an X-ray, what happens is the periosteal newborn deposition. Sorry, this one thing I forgot to explain. Now when we saw, going back to the picture of when we saw, how the pus trickles down. So when you actually, this is the periosteum and this is the collection of the pus. So here what happens is, this causes a subperiosteal reaction. It is called as subperiosteal reaction. So in such cases, what happens in a answering back to the reacting back to this particular reaction, there will be new bone deposition at that site. Okay, so that is a response to that reaction. This new bone deposition, okay, is the main first earliest symptom to be seen on X-ray. And that does not happen on day 1, day 2 or day 3. It minimum takes almost 7 to 10 days to appear. Okay, so now we know another important point. That's why it is important to diagnose osteomyelitis at the clinical level. Because these things, leukocytosis and ESR may also be raised at the, septic arthritis or any other pyogenic arthritis or infective, any infections apart from osteomyelitis. Again, you will find all these symptoms. And the first thing to appear on X-ray is, it takes 7 to 10 days. Now, you can go for bone scan, which, detects things a little more earlier, but not all patients who come to you can afford a bone scan. So, what does actually bone scan do is, so it is done using technetium actually, 99. So, here what it does that, it will, start detecting the increased uptake of bone in the metaphysis. Okay, it will sense the increased uptake of bone in the metaphysis. So if that is sure, then it is said that this is positive before the changes appear on X-ray. So only at this level, a little bit earlier, can the pathology be detected with a bone scan. You need not wait for another 7 to 10 days. I'm not sure of, at which particular day this can be done. I'll just refer back and let you know in further classes. So as of now, the third investigation is the bone scan. And the next one is aspiration. So suppose when the patient comes, you can feel the abscess, then obviously you have to go for an aspiration cytology. Okay. Because of which you get to know the CNS, you get to know which is the pathogen. You can immediately start off with it. The antibiotics is one of the prime treatment protocols for osteomyelitis. So with this, it helps you to drain the pus completely. So these are the investigation part. Now, coming to the differential diagnosis. One, during the course, I have already told that it is an hematogenic arthritis. Now coming to the differential diagnosis, as I told, any inflammatory disease of bone becomes a DD for acute osteomyelitis. Now, which are the basic ones? We will see it now. So, the first one we have is acute septic arthritis. Now, how do we differentiate this is, so we have the tenderness and increase in warmth and pain. Everything is elicited at the joint level. Okay, so the increased tenderness, even the swelling is at the level of the joint and not at the level of metaphysis. That is the first one. Now, next one is, in case of osteomyelitis, there will be no pain in moving the joint, but there will be pain at the level of metaphysis. Here, on the contrary, movement of joint will be painful. So, the movement of, if you want to elicit any range of movements, that is very, very painful in case of acute septic arthritis. Now, the next thing is, suppose if you are, you want to confirm it doubly, it is not needed actually. In spite of that, you can go for an aspiration of the joint fluid. Okay. So, in case of osteomyelitis, if it is extra-articular, the joint will not be, you cannot find pathogens in the joint fluid. Whereas in case of septic arthritis, you go for a positive pathogens in the joint fluid. So then it confirms the diagnosis of septic arthritis. So this is how you differentiate acute septic arthritis. Now, the next one is acute rheumatic arthritis. Okay, though the pain, tenderness, swelling, everything is common with respect, between septic arthritis and rheumatic arthritis. Okay, so what is that important thing with respect to rheumatic arthritis here is, we have fleeting pain in the joint. So this is very important. This fleeting pain is not seen in case of acute septic arthritis. Another is, obviously, when you go for ASLO titer and CRP, it comes in favor of RA. Suppose it is an acute rheumatoid arthritis. Okay, so with this you can again differentiate it with osteomyelitis. Okay, now the next important thing is, in cases of scurvy. Okay, so here what happens is, suppose this is the long bone and this is the periosteum. In scurvy, what happens is that there is, subperiosteal hematoma. So hematoma formation is evident in case of scurvy. Okay, but so this mimics osteomyelitis on a X-ray, because even in case of X-ray you have the subperiosteal collection. Even scurvy mimics OM with the radiological investigation, but clinically there will be no pain, tenderness or swelling in that area. Okay, there is no pain or swelling. Okay, that is how you differentiate scurvy. Okay, and here you will not, all the inflammatory response, no inflammatory response, right? So even fever is absent. That is how we differentiate. Now the next one, especially happens in children. So another very important differential diagnosis is the acute poliomyelitis. Okay, acute poliomyelitis. Now, even though it is coming to a decline, for the knowledge, it is important for us to know of how, why acute poliomyelitis is important, because in acute phase also of poliomyelitis, there is fever and the muscles become tender. So here there is fever and the muscles that are tender. But now we know that in osteomyelitis, it is not the muscles, it is the bone pain. So when you are palpating the muscles, we do not have pain, but we want to palpate the bone exactly, then there will be pain. So that is the differential aspect of it. So we are left with 10 minutes more. We will complete the treatment aspect and wind up with acute osteomyelitis. So now moving on to the treatment aspect of acute osteomyelitis. So the first thing is that Early adequate treatment of acute osteomyelitis is the key to success. I already told you earlier that immediate intervention and adequate intervention is the key of success for, you know, treatment success for you to prevent or arrest the disease from moving on to the further stage. So for this, what you have to do? Now, treatment completely depends on when the patient is brought to you. So for that, you can categorize it as when patient is brought before 48 hours and after 48 hours of what? Of onset of the pathology. Okay. So now what if it is, now the first thing what we will see here is before 48 hours. So what are those important things we have to look for is, now what is the, why there is change with respect to treatment thing is that, so suppose if it is brought 48 hours before, a general notion or the assumption is that, you know, it is still not ended in the formation of the pus. So, you know, it is easier for you to arrest the disease at that stage. So that is the, you know, importance of classifying the treatment into before 48 hours and after 48 hours. So suppose the child is brought within 48 hours of the onset of symptoms. Now, so what do we assume? That the pus has not yet formed and the inflammatory process can be arrested. So that is important. So you want to arrest the inflammatory process and there is no pus yet. Okay, pus is not yet formed. So what do we start? So the mainstay is we have the rest antibiotics and the general, you know, the general build-up of the patient. So now coming first to, you know, the rest part. So what we do is rest. You rest the limb in a splint or by traction. Okay. So this is the first thing what we do. Now the next is that you have to start compulsorily with broad spectrum antibiotics. Okay. Alongside, you have to also give it for a cultural sensitivity. So until then, you can go for broad spectrum antibiotics. Now, once the cultural sensitivity report, you know, comes, so here then you know, specific antibiotic with respect to a specific pathogen is taken for. Now, the general you know, choice of the antibiotic, it is usually cefotaxime 100 to 150 mg per kg body weight. It is, you know, given with a combination of amikacin. Okay, so usually this is chosen with amikacin. Okay, so once the report appears, you can go for a specific antibiotic. Now, this very important is that for the first 2 weeks, okay, this has to be given IV. It is very, very important. Okay, so all these specific antibiotics are given IV for the first 2 weeks. Then now next, what do we have? Next is that you know, rehydration. We saw that, you know, the child is severely dehydrated. So rehydration is the next important thing. IV fluids are given. Okay, so this is the next thing. Now what is the next we have to look for is that, now you have to look always assess for the response. Okay, before that we have to make a daily chart of the vitals, especially the temperature and the pulse rate. This should be done every 4th hourly. Okay, this is the next important thing. Now after, you know, monitoring chart is done, next what you have to do is that it is always good to, you know, outline the area of tenderness. Excuse me. Now what is outlining the area of tenderness is, now suppose earlier this was, you know, you can use any you know, a matchstick or anything or a pen or something of that, and you ask the patient, you outline the area of tenderness. So earlier when you start the treatment, before, if the tenderness outline was this big, you know, when you're starting with the treatment, if the patient is responding to treatment, assessment of the patient's response to treatment is very important in case of osteomyelitis, because even after 48 hours, if the patient is not responding, then it signifies that you have to go for a surgical intervention and you have to remove the pus out. So that is very important. So for that, you need to analyze, outline the area of tenderness. Means what? Before treatment, if the outlining the area of tenderness was this big, patient is responding to you. When as and when the fever and inflammatory response is subsiding, the area of tenderness should also decrease. So maybe, you know, after a few hours, when you again draw an outline, this might be so small. or it might be smaller. So this is an indication that the patient is responding. So that is also one of the protocols, that is outline the area of tenderness. Okay, so these are the basic things. Now after this, once 2 weeks of IV is finished, it doesn't end there. You have to give specific antibiotics for 6 weeks orally. Okay, so this is very, very important. Now suppose, as I told you, very important is, if the patient is not responding to you even after 48 hours, then it is a strict indication for surgical intervention. Okay, so what is that? Now what happens? How do we do the surgical intervention? Or the same thing is, if the child is brought to you after 48 hours of the onset of pathology. Now the second aspect of treatment, that is after 48 hours, or if the conservative treatment has failed with up to 48 hours, then this is the same intervention. Now what it goes for is, so the first thing is that it says that already there is a collection of pus. Already there is collection of pus. So what do you do? Wherever there is pus accumulation, once it is formed, the first thing to do is to let it move out, because otherwise it will start trickling further down and it will cause much more complications. So you have to get this pus out. So how do you do that? Now suppose it is from the subperiosteal region. It has disrupted the area of periosteum. It has come to lie in the muscular plane. Then you have the skin. So it is, the drainage is possible. Otherwise, sometimes what happens when it is deep at the level, even subperiosteally, it is still subperiosteally, then it is important to drill a hole through the bone tissue. Okay, so this is important. So what do they do here is, a drill hole is made. Okay, so here okay, so when a drill hole is made, so what it is called it as, if the pus wells into the hole, suppose like this is the hole you are making and you are able to see the pus, then it indicates that you are at the right side. So when the pus, pus wells into the hole, then what they do is they enlarge this. Why do they enlarge it? Because, it is every chance for the collection of pus there. So let it, facilitate easy drainage. Okay, so to facilitate easy drainage, we enlarge this part and they make the drain flow out. So, obviously the pus is coming, so it is important, mandatory to send it for cultural sensitivity. Now, does it end here? So the pus has come out. So is it that we pack everything inside and put up a bandage? Not at all, right? So there will be more, exudate part which will be coming out. If it is made to, arrest inside, it will again trigger the problem. So it is important for the exudates to drain out continuously, for which we have surgical drains, sterile surgical drains. Usually it is seen, they are used in many surgeries, especially for the abdominal surgery, abdominal thoracic surgery, when, there are many kinds of drains, active drains and passive drains. Again, that itself is another big topic. But as of now, here what they do is that they connect the sterile drain from wherever is the cavity to the outside of the body, so that because of the suction pressure, whatever is the vacuum, the negative pressure inside, whatever is the exudate coming, it comes outside, and there will be it is a closed. Again, there are many types: open drain, closed drains. So usually in a closed drain, what happens? The pus will come and it will get collected in the drain. Okay, the exudate. So there will be markings on the drain, because from which you can get to know what is the amount of exudate. So a drain is placed and the rest of the dressing is done. Okay, so this is how we go for the surgical intervention. So here, when antibiotics here also, once you get to know the infection is in control, when the pain reduces, in both the cases, it is, as I told, the limb has to be kept in rest, not continuously for 6 weeks. The limb has to be in rest until when the inflammation and the pain reduces. Once all of these comes down, then you can use the limb. So here also, after all this, you have to take antibiotics for 6 weeks. Okay. So this is the surgical intervention. Now, we have the complications very importantly. So the first thing is, complications are divided into 2 types. We have general and we have local. This is the last part, and I don't want to leave this tiny portion to the next session, so I want to complete it. I need an extra 5 minutes. So this is, we have the general and we have the local. So general, again, it is, it is more prone in the child. So suppose it is not controlled infection, it could lead to pyemia. So in such cases, it proves fatal. So in cases of pyemia or septicemia, what happens? If it is not controlled, then both of these could prove as fatal. So this is the general. Now, in local complications, what is the important ones in the local complication? This is more evident actually, okay, local complication. The first one is chronic osteomyelitis. So what happens? Suppose you're not, it is not identified in the early stages, treatment is inadequate, then it moves to chronic osteomyelitis, okay? So, there are hardly any radiological features in the early stage. So, in chronic osteomyelitis, what happens? The bone appears more denser. When we deal with chronic osteomyelitis, we will look for the radiological aspects. So, this is one complication. The next complication is acute septic arthritis in cases of intra-articular joints. We have seen that, right? Now, what is the next complication? After that, we have pathological fracture. So again, in the first session or in the second session, when we were dealing with the, I think in the second or third, pathological fractures, osteomyelitis was one of the reasons, next to osteoporosis, right? So it ends up with, already the bone is rendered weak. So because of which even a trivial force causes a fracture to happen. So that will even worse the pathology. And again, as we saw that for an osteomyelitic bone, it is very, very difficult, and usually it ends up in a malunion or aunion. So, or non-union. So, pathological fracture could also occur. The next one is growth plate disturbance. Okay. So, how much ever, resistant the growth plate could be, during the action of resistance, some amount of turmoil do happens between the pathogens and the growth plate, right? That plate is disturbed. So supposedly, by chance the growth plate also gets infected. We know that cartilaginous plate has the prime important role in the lengthening of the long bone. If that only is hampered, then the growth hampers. So usually it is seen in children. So suppose if it ends up with, growth plate disturbances, then obviously what happens? You could even end up with, shortening of that particular limb, or the limb could be crooked. That is, there could be a deformed limb. So that is why it is very important that this could also be one of the complications of the local complications of osteomyelitis. So the secondary osteomyelitis is also, everything remains the same, but the etiology is that it is from an external cause. Now, suppose you have an compound fracture wherein the wound is open and, it is up to the level of bone tissue. Suppose it is in direct contact with the environment. So, suppose some infectious thing, invades inside through the bone to cause an infection. So, suppose in cases of fall or accidents, this or secondary osteomyelitis is seen. Especially in earlier days, secondary osteomyelitis were seen, after when the compound fractures are taken for operative procedures. So, back then, in the early stages of development of operative procedures for compound fractures, because you're opening up, especially when you have to go for an internal fixation, for an open reduction or an internal fixation, where you have to open the bone, open the tissue and then act upon the bone. In such cases, because of, the post-operative infections, acquired post-operative infections usually rendered the bone to osteomyelitic changes. But with the advent of very strict aseptic precautions, that has declined largely. So, but still, in cases of severe external trauma afflicting the bone, secondary or acute osteomyelitis will be seen. Otherwise, it's usually primary. So, with this, today we have completed on the very, very important topic of bone infection, that is osteomyelitis. So in the next class, we will take up a very brief note on the chronic osteomyelitis. It will not take much of the time as today's session. And we'll try to finish on the Chikitsa Sthana, that is the Bhagna Chikitsa of the Sushrita Samhita. So I would like to conclude today's session again with a prayer. Om Gnananandamayam Devam Nirmalasphatikarkritim Adharam Sarvavidyanam Hayagrivam Upasmahe. Om Shanti Shanti Shanti. Shubha Madhyana. Take care.